here. And I think we are recording now, so we're doing Derm Path Potpourri. Oh, I guess the last question that came up is recording the sessions. We have a lot of the Path residents who time shift, and hold on, we got to get it in focus up on the screen, and watch them later, not real time. So we're not just doing it for external, we're doing it for internal too, the recording. So maybe not, again, there are pluses and minuses. So we can look at, do we record everything? Do we record some things? Okay. Nicole, you want to start?
Sure. So in the center there, it kind of looks like you have a big thrombosed vessel.
Yep. And that's basically what you have. I think some of you have seen patients like this with me in East Cooper, where we end up tying off a big bleeding vessel in the leg of an older person because it just erodes through to the surface. And that's basically what you got. So this is, old guy with bleeding leg. Let's see this one here would be good. Let's get that guy.
Kind of, I don't know if it was just the cut, but they look pretty slender and there, but there's
So pretty slender makes you think of
syphilis.
So next thing you look at, is there an underlying busy dermis?
In the papillary dermis there.
So maybe papillary dermis, not so much down below that. Do vessels have clear lumens, or is there endothelial swelling?
I can see
Pretty good lumens. So, a couple of things may be against, but you certainly want to think of it with long radi, especially when they're slender.
That dermis is kind of thick in that area. Newts in the horn. Yep.
So lots of newts in the horn.
So T ticks, matrix, central, psoriasis, tinea, candida, hepatitis, subderm. There's kind of thinning of the reedy there. Maybe there's maybe a little, I don't know if it's sponge or not.
Yeah. So you definitely have spongiform pustule here. And are the newts throughout the epidermis, or are they patchy, alternating with para?
Maybe patchy, alternating with para. So.
Which goes a little bit towards which things in the differential.
It's like checkerboard and more like a PRP.
So the checkerboard parakeratosis alone, PRP.
But
The newts alternating with para, a little more psoriasis. Yeah. Psoriasis writers, which is basically psoriasis. So, when you have newts in the horn and they're alternating newts, para, that's pretty good for psoriasis. Let's go for high yield here. We're taking out some of the lower yield ones. Can't read what this is, but it looks like it might be something good.
First glance, I've done about a KA.
So, because you have big glassy pseudoepitheliomatous hyperplasia and neutrophilic microabscesses, what else could do that?
You have your pH with us, spleen. Some of them can as well. There's a lot of giant cells there, so you might want to look for a bug.
Yeah. So pH with pus, here come big green leafy veggies. And the answer in this case?
It looks like chroma.
That is the C in here come big green leafy veggies. We got chromomycosis there. And let's see, get that onto the screen for the Path residents joining us by screen. So there you go.
MUSC, it's like the epidermis system. So maybe like an area of generated collagen in the middle, it's necrobiosis, maybe on trying to decide if this is like layered or more of just like a palisated granuloma, maybe like granuloma annulare.
So your question is it layers like NLD, or is it patchy foci like GA?
So more like GA, I think, because it's not pandermal or side-to-side.
Kind of agree with you. The other thing is if it has mucin or fibrin, in this case it's more fibrin than mucin, intensely staining. If there's fibrin or mucin, it's more likely GA or deep GA with the fibrin. Whereas NLD, the collagen is pale. It doesn't stain deeper than normal collagen. It stains paler than normal collagen. Here, those areas are staining deeper than the normal collagen, which is more GA than NLD. So, well done.
So, looks like calcium deposition.
Yeah, calcium deposition. So something calcified. So in what? What is calcified?
This one is just like a fibrous, like almost like a fibrous word. It's hard to see.
So you've got lumens within it, right? And then around the lumen, you've got these cells, and they have little glycogen vacuoles in them. What does that suggest that they are? Spindle cells with little glycogen vacuoles. What kind of spindle cell carries glycogen as a snack?
Like muscle.
Yeah, like smooth muscle. So if this is a big marble of smooth muscle with embedded lumen,
Kind of like angioleiomyoma?
like angioleiomyoma, very good. And you just happen to have a little calcification in there. Okay, Brian, is this more like a marble or more like a pinwheel?
Pinwheel.
More like a pinwheel. So what is the pinwheel muscle thing?
I don't see a good capsule on it. I thought about like a PN.
And PNs tend to be vertically oriented and oval in shape, whereas this thing really has pinwheel arms sticking out from it. So what's pink in pinwheel? That's again, anyone want to jump? Piloleiomyoma. So angioleiomyoma is a marble. Piloleiomyoma is a pinwheel. Okay. P for pinwheel, P for pilo.
So dermal proliferation. Looks Merkley.
Looks Merkley. Why Merkley?
You got large kind of blue cells and kind of filling up the entire dermis.
So blue cells, smudged chromatin pattern, high mitotic rate, and in addition to being nodular, they sort of break up into parallel structures, sort of like the trabeculae in trabecular bone. So it's called a trabecular pattern, which is something Merkels tend to do. You know, they tend to do that a little more probably than some of the other small blue tumors do. So it kind of leads you in that direction. Probably doesn't replace immunostaining. What kind of immunostaining would you want to do?
CK20, TTF1, just to rule out other things.
So TTF1 to rule out mainly lung, right? Small cell lung, oat cell. And CK20 is good. NSE, synaptophysin, probably a little more specific than NSE. Very good. Okay.
It's verrucous pattern, and then there's hypercellular and acanthosis, and
So you said a verrucous pattern with papillomatosis, clotting of papillae, compact horn that changes to a coarse basket weave in areas, like someone has taken a little round cookie cutter and punched round to oval holes out of it, hypergranulosis in the dells, and the only other thing that we're not really seeing prominent in this particular example is a lot of round parakeratosis, although there is some. So this is, you basically started there saying verrucous pattern, so verruca vulgaris. Very good. Okay, this is just welcome to our life in Derm Path. This is what it looks like when you get curettings for basal cell. So, when your biopsy is done with a curette, this would be like really good. Usually it looks more like it's been put through a wearing blender, which is why, we tend to shave rather than curette, because it's really hard to help you in terms of pattern, growth pattern, whether it's going to be aggressive or whether it's something you can curette, which is why we tend to shave and curette, whereas the old guys just did curette and basically washed their curette in the formalin bottle. And
How do you approach one that's in like a cockle, like they have an ulceration in like their cockle balls?
so how do you get in there? You can often do the tip of a small blade. Sometimes you're even 11 blades, so it's like a really sharp little point that you're in there and you can get a shave under there. The other thing is often people's cartilage is more flexible than you think. You can get a finger behind there and just evert it. And if you can evert it without hurting them too much, you can get a flat plane where you can do a shave with a usually not a persona, but with a 15 blade.
An alternative route is also do like a saucerization with the, old school sterile shaving blades, the rectangular ones. You fold it. Of course, you have to grab it.
Yeah. And that's probably when you trained, you were using those, and that's 99% of the biopsies we do. We use them. So we're not the Persona safety blade most of the time with the blue plastic. We're the old-fashioned razor blade here because they are so multi-purpose.
There's a lot of acanthosis here, and going on in the upper epidermis as well. I'm not sure. And it looks like the kind of the clear cell change, a little marcated there as well.
Yeah. So the question is that primary or is that secondary change?
Right. I'm guessing it's more secondary.
More secondary to the stuff underneath. So what's the stuff underneath?
Wispy pink. I'm not sure.
Leave your condenser down so you can see this kind of feathery pattern.
Like gout.
Like gout, exactly. So you've got all your gout crystals. They become more homogeneous where it's been formalin fixed. When you get right to the center where the formalin didn't get, you've got more of the feathery crystalline pattern, which is why you see it preserved in little foci in a more smudgy background there. This one was dipped in formalin. If you put it in alcohol, then it preserves the crystalline pattern throughout.
So the melanocytic proliferation along the DEJ looks concerning for MIS too.
Yeah. So melanocytic proliferation along the DEJ. Is it well nested at tips and sides of reedy, or is it not well nested at all and there's more of it above the arches than at the tips of the reedy?
Single unit proliferation, not nested.
Yeah, and above the arches, and that's usually badness. Some little bits of flat bottom red fibrosis under the epidermis there, which is also a clue. That kind of stromal change.
So it looks like pretty good for a PEN. Or looks, or just a schwannoma. It has sort of that neural appearance, almost like some varicose body formation.
Yeah, so it definitely has varicose bodies everywhere you look, and it's encapsulated. So, given how close it is to the surface, maybe PEN or maybe schwannoma in like a dorsum of a foot where you don't have that much thickness to the skin, so it just looks superficial. It would, either be a big PEN or an ordinary sized schwannoma. So, one of the things that can help is look to see if it's really attached to a nerve. If you see a nerve trunk somewhere, then that's likely a true schwannoma. The presence of subcapsular edema in a crescent-like pattern, which you've got little bits of here, also help that you're more likely true schwannoma rather than PEN. Well done.
Looks like another piloleiomyoma.
Looks like another piloleiomyoma. So, pinwheel, pink, piloleiomyoma.
Those are melanocytes. It's like
So, well, the gray things are melanocytes with the little round black things.
Sides, looks like they're mingling. So maybe this is
like a halo nevus. So they are just mingling throughout the melanocytic lesions, so the pattern of a benign halo nevus.
So the acanthodic epidermis, it looks like pretty regular. Let's see what's in the horn there. It's very broad shape. Could be psoriasis, but are you pointing to A4O?
Yep. So remember cornoid lamella at the edge there, at the other edge. Center of poro can look like anything. It can be lichenoid, it can be psoriasiform. You've got at the edge the 45-degree angle parakeratosis, dyskeratotic cells at the base. Get it so that the top line can see. So porokeratosis, nicely done.
Very broad shade with a scar and a suggestion that maybe there was some melanocytic lesion here.
Yeah, and in fact you have some large melanocytes at the junction, right? And a poorly nested proliferation of melanocytes at the junction. So what do you think?
I would like to see the previous biopsy.
You want to see the previous biopsy. You are a wise man. So because you are thinking,
Current.
yeah, this is either recurrent nevus or recurrent melanoma, right? Probably recurrent nevus, common things being common, but if you can get a hold of the prior biopsy, that's where the answer is.
Biopsy. A lot of spongiosis, some areas, some parakeratosis.
Yep, parakeratosis. And is it all parakeratosis, or is there little fragments, little dark fragments in the parakeratosis?
Those neutrophils?
Yeah, probably some little bits of neutrophil debris. So what are you thinking?
Doesn't quite look like psoriasis.
So newt sitting on top of para, why does it not look like psoriasis?
I guess, yeah. That could be like more acute psoriasis, I guess.
So it's awfully spongiotic, right? So apparently the history was PR versus psoriasis. This is an old slide from somewhere. It was called PR. I'm not sure this isn't guttate psoriasis, because you have, little darker foci with nuclear fragments sitting on top of parakeratosis. What forms an acute psoriasis doesn't have psoriasiform hyperplasia. That comes later. What forms of psoriasis are spongiotic?
Erythrodermic, guttate, inverse, and erythrodermic.
Yeah, so erythrodermic, inverse acral, guttate are the types of psoriasis that are supposed to be spongiotic. So this really could be guttate psoriasis.
Do we call them up?
Well, we have no idea how to get a hold of them. I mean, this is a teaching slide sent in by someone. But and it's a common differential, guttate versus PR, because you got these little papulosquamous things. I didn't see much red cell extravasation there, and PR can be guttate psoriasis can be awfully spongiotic. So with those little dark fragments above the foci of para, I favor guttate. Okay, Robbie, what do you see?
So that's a necrosis of epidermis.
Yep. And what form of necrosis is this? Is this more through and through, like TEN, more reticular, like hand, foot, and mouth, or more ballooning, like herpetic?
I was going to say full thickness, but it's somewhat ballooning.
Yeah, it's ballooning. That's your clue that this is a herpetic blister. Right, so this is from a painful round plaques, edematous within a dermatome.
Zoster.
Yeah, zoster in old people, when it presents to you, often is not blistered. If it were blistered, they would have identified it in the ER and it never would have gotten to you, right? So zoster is often these perfectly round, painful edematous plaques that all occur basically within a dermatome. And, that's often the comes to the derm zoster, as opposed to diagnosed in the ED zoster. And so they're often biopsied for, to verify the diagnosis. Okay, Brian.
I think I'm in the DF realm. It looks like there's a little overlying.
So there's a little overlying acanthosis, and you got a busy dermis. Look at the edges. How would you describe the edge?
Not stellate, but
kind of like pointy.
Yeah.
Like the points of a pinwheel.
Oh man, this is my theme today. This is not pyelomyoma.
So another piloleiomyoma, and this is one. It's a little more subtle.
Yeah.
You can absolutely see. If I were putting a pick list, what would you put on your pick list? Maybe DF.
I still choose a DF.
So, know what your nemesis is and then review your nemesis, for Patty Malerich was famous, it was another frickin' warty disc keratoma. And so her peers got her for graduation a framed warty disc keratoma because that, was her nemesis all through residency, and it hangs on her wall in her office. They're those things that are easy and those things that, you might miss. And so review the ones you might miss. They can't read what this says, so we're just going to see what it shows. Ugh.
Is it like a bad squame?
Like a bad squame. That's exactly what it is. It's keratinizing. You see all that pink keratin. It's endophytic. It's jagged. Yeah, just a nasty looking squamous cell carcinoma.
It's a pH pattern. There is nodules infiltrate.
So you have lobule.
Yes, it's
hanging down from the epidermis, and it's palisaded.
Like cylindroma.
And it's pale. So the cylindromas often have the very bright pink base membrane zone around them. Here the base membrane zone, you can see it, but it's very pale around it, and it's attached to the epidermis and hanging down. So maybe more like trichomoma.
Trichomoma.
Things with larger rectatic vessels near the epidermis. Sure.
So you got large rectatic vessels, and what's lining the wall of the vessel? Are vessels usually lined by round cells? Usually you see like flat endothelium and smooth muscle. These are very round cells, kind of lining up in rows like a necklace.
Yeah.
Or
Yeah,
like a glomangioma. So a glomus is where it's a tumor of all the glomus cells.
Mm-hmm.
A glomangioma is where it's an angioma with just a little glome around it. Right?
This one looks very GA-ish.
Very GA-ish. So it's pale. You might stain it to see if that's really mucin in there. You have a little bit of neutrophilic debris, so somewhere between GA or PNGD, palisaded neutrophilic granulomatous dermatitis, which GA, if associated with anything, is usually diabetes in disseminated GA, whereas PNGD is usually arthritic, like smoldering connective tissue disease.
Pale.
It's very pale.
There's an area where the stratum corneum kind of goes away. I'm not sure if that's the primary.
That may actually just be artifact.
Yeah.
But looking at your epidermis, is your stain pale or is the pathology pale?
Well, both. But I would say
I would say your epidermis isn't particularly pale staining, right?
It's probably LSA.
Probably lichen sclerosus. And this is one that probably was even a bullous lichen sclerosus because there's just so much edema in that pale zone. So, just a really prominent LS.
There's definitely a ton of newts in the horn.
Definitely a ton of newts in the horn. So your differential?
His P-tics.
Psoriasis, tinea, impetigo, candida, septic,
There's
syphilis.
also a lot of EOs, though, in the interstitium.
There are a lot of EOs in the interstitium. You might even add like IgA pemphigus to your list. It might be a clue towards tinea, especially with a corneum that's a little bit layered with a compact under basket weave. So you would definitely want to do a PAS, but that would be your differential. Very good. Slide is labeled psoriasis. I mean, I would definitely get a PAS and look more at the patient.
This is, I mean, that's just all clear on it. This is just recent. There's kind of like a GA look or granuloma look on the other side.
So is this more granuloma or more lymphoid band?
Maybe a lymphoid band, so like LSA.
Like LSNA. And it's, a narrow band of pallor there and a great big band of pallor here, but all lichen sclerosis. Probably taken at the border of mildly involved and very badly involved skin.
Sort of had this story form proliferation, sort of slamming, but not quite. I would think about a leiomyoma, but
Exactly. See how at the end it's pointy like a pinwheel? That's a clue to leiomyoma at scan. That those fascicles end in points at the edge. So it is in fact another leiomyoma. Like an angiokeratoma. You've got your angio stuck up in the papillodermis, and then above it is the keratoma part where it's warty with compact hyperkeratosis.
Pretty dense lymphoid, lymphocytic infiltrate. Papillodermis.
Are all the cells dark or some gray?
Some gray, so maybe this could be melanocytes. This could be.
So if those are melanocytic,
Then the infiltrate's kind of like walling it off a little bit to me.
so your question is melanoma versus just inflamed halo nevus, right? So look at your melanocytic proliferation. Is it broad or is it well circumscribed?
I mean, it's pretty well circumscribed.
Pretty well circumscribed. Nests, round to oval, tips and sides of reedy. Anything in the arches? Not really.
Yeah, it's more of a halo nevus.
More of a halo nevus. Well done.
So it looks like kind of some almost ballooning in the superficial epidermis.
So is it ballooning like acantholytic ballooning, or is the epidermis holding together? It's just vacuolated with blue nuclei surrounded by clear.
Kind of blue nucleus surrounded by clear.
And then there are little holes in the epidermis punched out that are about the size of these circles below. So what is this?
It's like a kind of wart, I was going to say.
Yeah, like a flat wart.
Flat wart.
Okay. So in flat wart, you have these round coilocytes in the granular layer, and then the holes in the corneum are exactly the same size and shape as the coilocytes below them. Right? They're a shadow of the coilocyte once it's been keratinized.
Very acanthotic, hyperkeratotic.
Acanthotic, hyperkeratotic. crusted.
Yeah, I don't see a lot underneath. Let's see.
So if we focus on the neutrophils in the horn, what would be your differential?
This is your PTEX again, so psoriasis, tinea, impetigo, Candida subderm, or syphilis.
And, so this could be like a mucus patch, corner of someone's mouth of syphilis, absolutely could look like this. Could be verrucous candida, like a verrucous perleche with candidiasis. Could be a hyperplastic psoriasis, could be any of those things. Apparently on PAS it was loaded with candida. I have seen syphilis loaded with candida, so you might want to, it's a macerated mucosal surface, so you might want to just go that one extra step.
Looks kind of paisley dye-ish.
That's why I wore this tie today.
Perfect.
Right, there we go. So we're all set. So paisley tie. Okay, so this is from a 15-year-old with Downs and the little bumps on the eyelid. But that's a lie. This is from an 85-year-old with a large scar-like lesion on the forehead. But that's a lie. It's actually a young woman with a pale donut-like lesion on the cheek. But that's a lie. It's actually Mac was the only one left, which would be the big red plaque on your lip where the sauce from a Big Mac gets you.
Oh, it's like a nodule infiltrate in the dermis and the tumors from neosarcoma. Looks like
So you're thinking maybe leiomyosarcoma?
Yeah.
You certainly see the vascularization telling you that it's smooth muscle and the long cigar-shaped nuclei. So probably the best thing to start, and at the edge, it's a little pinwheel. Those are kind of blunted off pinwheel. Someone's taken scissors to this pinwheel. But look at the degree of cellularity. Is that about the same density of nuclei as erector pili, in which case it's benign? Or is it a much higher, denser cellularity compared to erector pili? This one's not that far off from erector pili. So probably benign leiomyoma rather than leiomyosarc, given that.
Proliferation in the dermis. I think kind of looks similar to Merkel's.
So are these forming nodules or are they lining crack-like spaces?
More lining crack-like spaces.
So what are you thinking?
Like Kaposi's or...
So Kaposi's are the cells round and hyperchromatic lining crack-like spaces, or which?
Not.
So which one is more like that? Anybody?
Angiosarcoma.
Yeah, more a conventional angiosarc. KS is a type of angiosarc, so you get heavy partial credit for that. But this is more like old man bruise on the forehead, angiosarc. Round hyperchromatic cells lining irregular crack-like spaces in the dermis. Looks like a pilomatricoma. So, beautiful shadow cells, some osteoclast-like giant cells, and I don't see any baseloid cells left. If you saw ossification, then you could say a bona fide example of a pilomatricoma. Yep. I never tire of it. It's pretty pathetic.
So, definitely a pretty large epidermal proliferation with what appears to be lymphocytes underneath.
Yeah, so definitely a host response. Host doesn't like it,
It's,
right?
I think it's in the poroma category, the way those cells are looking.
Hush.
Yeah, so maybe not. A lot of mitoses.
Yeah.
Still kind of have, maybe it could be a porocarcinoma.
Could be porocarcinoma. I'm sort of between porocarcinoma and Bowen's. Either a big, thick acanthotic Bowen's or porocarcinoma. Both are essentially adnexal carcinoma. This looks like it's becoming invasive, probably in areas. Both are bad actors. So it almost doesn't matter if it's porocarcinoma or invasive Bowen's. Both are bad.
That looks like Merkel.
Looks like Merkel. So here you've got those long parallel and anastomosing strands or walls that look like trabecular bone in patterns. So that's where it got its old name, trabecular carcinoma. You can make them out pretty well here, those long parallel things of blue smudgy cells. So looks pretty Merkel-y.
Too much there's deep.
Yeah.
So some type of hyperchromatic.
So first off, how old do you think your patient is? That's pretty small striated muscle, right?
Right.
So this is probably baby. One of the junior set.
I don't know if it's the blue cell tumor in the dermis, like a neuroblastoma or something.
Well, so especially with the pink centers, neuroblastoma would be absolutely something you'd think of at scan, because you got blue cells around pink centers and you're in a younger patient. So you'd think neuroblastoma. There are a lot of erythrocytes there too. So with the erythrocytes, you'd wonder about tufted angioma kind of thing in a young kid as well. So that would be kind of your. And they called it looks like it says caposiform, so they called it a KHE rather than a tufted. So it doesn't look so caposiform, it looks more tufted. Both can be associated with Kasabach-Merritt, and my guess is it was that association that made them want to call it a KHE. Do you want this on you?
No.
So what are you thinking? What variety of bad is this?
Sort of looks glandular, like an adenocarcinoma.
Yes, you'd wonder about adeno versus just squame. It doesn't particularly palisade, which helps that it's less likely basal. So you'd want to look carefully for lumen formation. I'm thinking this is more likely just an acantholytic squame rather than something with true lumen formation. You can always get a musicarmine if you want to see if it's real adeno differentiation.
There's a blister.
And what's in the blister?
Dermal, there's neutrophils.
Neutrophils. Yeah.
Could be linear IgA, lupus. Not sure about.
So neutrophil-rich pemphigoid would be in there too. You mentioned bullous lupus, linear IgA, EBA would be in there in the differential, and DH. Any of those could give you this pattern. And this particular one had granular vertical picket fence pattern of immunofluorescence. So that's DH.
epidermis. Kind of looks like a basal cell.
Looks like a
It's got
basal.
some stromal clefting, yeah.
So next question. You did biopsy and curette. Are you done? Why or why not?
I'm guessing no. I mean, there's definitely tumor to the margin, but also that stroma, that's myxoid stroma is going to the margin too.
Yeah, and is it a conventional hypocellular myxoid, or is it very fibroblast-rich stroma?
It's fibroblast rich.
Fibroblast-rich, and the tumor is spiky,
Spiky, yes.
right? So that's going to be
pattern.
something you cannot define with a curette. You know, that's an infiltrative pattern, and it's going to be nasty underneath. So you did biopsy and curette on this. You got to go back because you can curette hypocellular myxoid stroma. You can't curette this stuff.
All right, so lots of, looks like acanthosis, and the dermis you've got kind of just punched down on this vacuolated appearance.
So what's in the vacuoles?
Is that crypto?
So they are pleomorphic yeast within common gelatinous space, so that is crypto. Most fungi like single-family homes, crypto like apartments or condos, right? These gelatinous condominiums with multiple pleomorphic yeast in them, that's crypto. Okay, Brian, and it's not a leiomyoma.
Are you sure?
Are you sure?
So this is big and ugly. Infiltrating the fat. Really tall, let's see. Also has kind of a Merkel look to it.
Yeah, it does have kind of a Merkel look. It's definitely trabecular in pattern. You'd want to stain it, but probably Merkel given that. Okay, we used up the hour and we got through 50 slides. When we're really cooking, we can do 100 in an hour. So just for the, for the discussion, most